And now it is my very special privilege to introduce my friend and colleague, Barry Hunt. Barry is well known to many of us, and most of us, I think, in the COVID conscious world. He has a long track record of advocacy in the area, to be sure. His background is in the biological and biomedical sciences at the University of Guelph and at the University of Waterloo. He's worked in healthcare. He knows how it all works. Um, in his most current endeavor, and I think about 7 years ago, he founded the Coalition for Community and Healthcare Acquired Infection Reduction, known as CHAIR. And I have the privilege of serving on the board of CHAIR. Um, Chair is a organization, really a collaboration of a whole bunch of people from academia, industry, healthcare, whose primary modus operandi is reducing preventable community and hospital acquired infections. And they are sponsoring and have sponsored research, clinical trials, education, installations of a variety of technologies, and are continuing to develop protocols for more academic studies of newer technologies, including ultraviolet light, which is, got great potential. Um, he is currently still the president of the Canadian Association of PPE Manufacturers, and he has been leading the pack in some of the improvements in PPE, making them lighter, easier to wear, and now working towards even biodegradable PPE. I could go on a long time about Barry. He's a general great guy, and he's in his knowledge of engineering methods to prevent infections is encyclopedic. And I keep trying to outsmart him, and I just can't. It frustrates me. He knows so much. So anyway, Barry, I'm going to turn it over to you, and we're anxious to hear your talk this evening.
Yeah. Well, thank you very much, Dr. Zupman. And so I've known Dr. Zupman for maybe 20 years now, and he's a pretty smart guy. And there's a saying that is it too soon we grow old and too late we grow smart. Well, I think he got smart earlier than most, and thankful he's still around to carry it through for everyone in his retirement. And I wish the rest of the ID world and IPAC world could keep up with Dr. Zeltman. And anyway, thank you very much, Deco. So I just wanted to start off. First of all, I'm very impressed with your organization. And thank you for letting me, audit your annual general meeting. It was very eye-opening. It's amazing what you've accomplished in just 2 years. Chair has been around for since 2014, so 12 years now. And anyway, it is amazing when you start a new venture, you don't know where it's going to go or what kind of legs it's going to have. But I can tell you, as an outsider looking in, you're well structured, you've got great talent in leadership, you've got the drive, the initiative, the professionalism, I think, to go the distance. And so, congratulations to all of you. And one of my favorite quotes is from Margaret Mead, and it says, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." And I think I'm looking at one of those groups right here. So thank you everybody for what you're doing, and I guess we'll get started. Hmm. Maybe I can share my screen. Actually, one other quick thing. John Cleese. I don't know if everybody knows John Cleese. He's from Monty Python. He's a pretty funny guy. I was on the board of a performing arts center, and we had a chance to bring in John Cleese to do a 1 hour lecture. And this was not a comedy lecture. This was an educational lecture. And he delivered the most riveting performance. And he talked about how there are very few leaders in the world who are actually making a difference. And it doesn't matter what industry. You could be an airline pilot, you could be a doctor, a nurse, sweeping floors, IT, doesn't matter. Out of 100 people, about five are leading the group, five are really committed, five are really doing the job, and 95 are phoning it in. And so you really have the leaders and the followers, and it's very few people that are really making a difference, and even fewer who are stepping up and doing the volunteer type of advocacy work that you're doing. So, okay. Well, when Dr. Zoutman talked to me about speaking here tonight, we talked about the subject and how important the coalitions are and working together is and collaboration is. And so that's why the topic Onward Together, and how important grassroots action is, more and more important as time goes on, it seems. And and I think there's a lot of similarities between our organizations. So I'm very privileged and thankful for the opportunity to talk to you here tonight. Um, so what do we do when our institutions fail us? Well, we start our own, and then we connect with others who have started. And so Chair is involved with a couple of different organizations, the World Health Network, which some of you likely are as well, at Canadian Coalition for Green Healthcare. I was there as a founding partner 26 years ago when that organization started. And all of our groups can do a lot more working together than apart. And I know you know this because I just saw your presentation, how you found other allies and are working together. And it's really amazing what we can do when we bring these organizations together. Our group started in 2014. Dr. Zoutman is now part of our core research team as well as on our board. And so we started as a fairly small group focused on engineering the environment. So engineered infection prevention, or EIP. And we've since added quite a few people who are regular contributors now to chair in a number of different fashions, whether it's on a specific research project or it's just in general. And so it's continued to grow. And basically, we're trying to inspire and guide people to engineer safer environments. And we feel we need to have a better than 90% reduction in exposure to pathogens in air, water, and surfaces to make a significant difference in transmission of disease. And we can do that with respirators, and we can do that with materials, and we can do that with technologies. And that's really our area of expertise is prevention. Um, and our role really is to do studies and to project manage those studies and help the development of materials and technologies, et cetera, bringing people together to figure out those solutions. And then to help write CSA standards or initiate new CSA standards so that we can put those materials and technologies into action. And then, of course, teach people, talk about it, educate people. So air, water, and surfaces, and then the combination of them, so spaces. So it might be, for example, sensors with automated reaction to occupancy. So when people go in and out of a bathroom, for example, you'd flash the room with UV and disinfect all the air and the surfaces in that bathroom before the next occupant goes in, for example. And so we have some big game-changing technologies. We feel that we've worked with companies over the years that to develop, and these are Canadian technologies. So one for continuous air disinfection. That's air is airborne transmission is suddenly well recognized since the onset of COVID. Continuous surface disinfection, continuous sink disinfection, because we have very deadly organisms growing in our sink drains that are getting aerosolized and then inhaled. And we have exponential growth of these organisms in sinks, mostly in healthcare, traveling all around the world now. So the numbers are still low, but they're growing and the mortality rate's very high. And then, of course, spaces themselves, so the combination of air, water, and surfaces. So there's lots of different technologies that can be brought to bear, but there are some that are more significant than others, and we really focus on the ones that can deliver more than a 90% reduction, and some can deliver as much as 99% reduction in exposure. Ontario, BC, and Manitoba have been very good at funding EIP technologies when they're building brand new hospitals or if they're redeveloping new hospitals. And there are challenges and hiccups, from time to time. But in general, they're favorable to putting in EIP or funding EIP. And a lot of that has to do with the cost benefit of putting in materials and automation and technology that will automatically reduce that HAI rate because it's very expensive to treat. So people are starting to recognize that when you wash your hands or you flush a toilet or anytime you do anything with water, you're liberating invisible aerosols into the air. You can't create droplets without creating like visible splash that you can see without creating invisible aerosols. And just the process of water itself hitting any obstruction, including more water, like a raindrop hitting a sidewalk or just dropping into water, you have a burst from the surface tension of the water itself that liberates these invisible little aerosols into the air. So when people talk about the splash from the sink, there's the splash is one thing, but it's splashing and landing and generating all these little invisible aerosols as well that until recently was really not well recognized in healthcare. So we have this invisible milieu of stuff floating around, not just from water, but particles being shed from our skin and our hair and our clothing, etc. That every time we touch something, we're liberating things into the air. And every time we walk or move, we're liberating things into the air from us or from surfaces, etc. So fomites that they talk about, where things land on surfaces, those landing pads are also launch pads, so they relaunch particles into the air. Something that's on the floor when you walk across the floor ends up on an overbed table in a patient room where it can contaminate people then. So the swirling stuff all the time is just something to keep in mind. If we're to culture typical surfaces in healthcare environments, our plates look like this. We want them to look like that. That's a pretty significant difference. There's no way to get plates to look like this if you're just using chemicals and cloths once a day in patient rooms, for example. But it's really, really easy to do if you're using materials and technology. Same thing with our air. Our dilution ventilation today gives us, so even when we follow the CSA standards, et cetera, it ends up generating about 50 to 500 colony forming units per cubic meter in our spaces. Sometimes even higher, 1,000 or higher if we have a really, crowded waiting room, for example. And we want to get it down to 5. Well, we can't do that with dilution ventilation. We need other solutions for that. We'll talk about that in a sec. So my colleagues and I at Chair have been working both individually and then together as Chair to bring in all kinds of different technologies into healthcare over the years, and then put all kinds of guidance into CSA standards over the years to try and make hospitals safer. And we had a really big improvement in 2011 when we brought in the hospital design standard and called for single patient rooms. And that was a real big fight that went on for 20 or 30 years before the standard ever came out when we committed to single patient rooms. But it automatically cuts infection rates in half as soon as we do that. And that's evolved now. So the latest version of the standard has a significant amount of EIP guidance in the standard, and I'll cover some of that here in a few minutes. So started in 2011, 15 years later, we're putting some technology into that hospital design guidance now. Cleaning disinfection standard, Chair raised the funds for that to initiate a new standard at CSA. It was just published in March 2020, just as COVID was starting here in Canada, and it's now on its second iteration, and there's a fair bit of EIP in there that I'll talk about in a minute. And then the respirator standard, Chair's involved with that respirator standard as well. So in the respirator standard, there's a new chapter in there that provides healthcare specific guidance. Obviously, a lot of people here know about it. You participated with Do Not Harm BC to submit a lot of comments that were well received. Thank you very much. And so there's some different concepts in here. You have to have a qualified person follow the precautionary principle. There's a very informative healthcare annex. And this concept of exempted zones. So universal respirator use, unless you're in an exempted zone. So the default is wear a respirator as soon as you go in until the time you leave, unless you're in a space that's been designated to be safe, where you can take it off. And you can engineer that or use a variety of things to determine whether that's safe or not. Now, there's some challenges to some of these concepts. The standard is not finished yet. It's been through 2 public reviews. It's about 2 years overdue in being published. And there's some ongoing challenges to, to getting it finished, but we do hope to get it out, or I certainly hope to get it out this year. On the hospital design side, so some of the new guidance that's in there, you need to hire an EIP expert now in your design team when you start to think about doing a project. And follow the precautionary principle, use the latest technology. There's a big informative annex in there. And here's the, I think, big game changer for a lot of people, mandatory cost benefit analysis. So what happens if you put this stuff in, you build it into a hospital that's got a life cycle of 30 years, you spend some money up front to make it safer? What kind of a performance outcome do you get? What kind of improvement in productivity? What kind of a, more beds available and et cetera, et cetera? What impact is that going to have throughout that 30-year lifespan? So that has to be calculated now. And specific guidance in there. So you have to plan that building to be safe for all occupants in the building. So patients, visitors, and staff. And not just patient to patient or patient to healthcare worker transmission or vice versa, but the building to its occupants. Follow the precautionary principle, including automated infection prevention technologies. So, I mean, it couldn't be clearer that you need to consider these now, and then, of course, do the cost benefit analysis with it. So, example of fixed and automated UV room disinfection would be a device, again, like an auto UV in your bathroom or a patient room, and then upper air UV, for example. And the very first upper air UV installation is going into the Ottawa hospitals in the waiting rooms on their main level for the new hospital they're building there. So that'll be the first substantial installation of upper air UV. You have to look at the effectiveness of the technology that you're looking at putting in, and the likelihood of achieving the intended outcome would be, reducing 90% of the exposure to those pathogens. Cleaning and disinfection standards, similar language. You need an expert on the team, follow the precautionary principle, use the latest EIP technology, informative UV annex, and mandatory cost benefit analysis again. So that's for ongoing buildings. So no project required. Compare what you're doing today, cleaning with chemicals and cloths once a day, to what you could be achieving in a reduction if you were to automate systems. So that's, to speed up the implementation of a lot of these. So in our rooms here today, we're allowing airborne transmission. So 25 to 50% of COVID cases and somewhere with flu cases are acquired in the hospital itself. And that's reported cases. And as we know, there's some underreporting of HAIs and for a variety of different reasons. So our 6 air changes an hour in patient rooms is not enough to stop airborne transmission. It's a good start, but it's not the it's not the end. And so there are 4 different ways that you can supplement that to get a 90% reduction. Here's me in a hospital 6 months ago, and I've got a CO2 monitor on my side of the room reading 705, and the other side of the room is reading 583. Well, why is there 120 part per million difference, across that 10 feet? There shouldn't be, right? It should be fairly similar across the room. There might be a slight gradient, but it shouldn't be that much. And then if you look up in the ceiling, you see the supply air is coming in right above where I was. And 1 tile away is where the return is going. So everything is just short circuiting. The air is coming in and going right back out. And so we have a lower CO2 over here, but where the patient is breathing in the other side of the room, it's a higher CO2. And so there's a lot of things, even when you have 6 air changes an hour, for example, you don't really have 6 air changes an hour in all the air that's in that room. And so those are some areas that Chair is exploring now, is how air is distributed in rooms. So that's part of a big project that we have going on. And not just the air itself, but the particles and then the biological particles that are in the air, or specifically the bacterial particles that are in the air. So in following the CSA standard currently, you'd have to vacate a patient room for 4 hours before you had a better than 90% reduction in the pathogens in there. In fact, there's studies that show transmission of COVID in patient rooms after a terminal clean, when a patient has gone home, 4 hours later, after the new patient comes in, after you've scrubbed the room, they've gotten COVID from that room. So 4 hours is not even enough at 6 air changes an hour necessarily to remove the pathogens from the room and terminal clean. So Chair is looking at doing a big study right now for upper air UV to look at real-time reduction of better than 90% in patient rooms. And if we understand what's happening to our warm aerosols as we speak and breathe and talk, um, those warm aerosols are rising up in the room. So 30-degree aerosols we're exhaling in a 20 degrees Celsius room, we get about 1.2 meters a second of travel upwards. And so just a couple of seconds after we've spoken, our aerosols are right up here, right above our head. And that's the only time we really know where they are in the room, and that's when we can treat them. Back in the mid 1800s, another hero of mine, Florence Nightingale, um, was designing her Nightingale wards, and she was designing them with high ceilings, transom windows with an airflow, heat source here, lots of sunlight, and she had upward airflow, otherwise known as displacement ventilation. So, working with people's warm exhaled breath, she would bring the pathogens up and exhaust them out the transom windows. Now, they didn't know it was exactly what was going on at the time. And there was, no name such as displacement ventilation. So this was all just done in an iterative process where you're actually just observing what is happening. And so she was one of the very first hospital designers that was designing for patient outcome. And it's just amazing some of the things that she came up with. In an airborne isolation room where we have 12 air changes an hour and we have infectious patients quite often, we exhale pathogens and they travel and circulate in that room for 20 minutes or so before they find an exit, the way we design them now. Whereas we could have overhead extraction, for example, and extract those pathogens immediately before they interact with anyone, and we'd have safety within the room. So rather than just maintaining negative pressure so we don't allow pathogens to escape into the hallway, we could actually make the airborne isolation room a safer environment as well. And that's what we can do with upper air UV. So this is fan assisted upper air UV. As soon as you add a fan to UV, you can draw a lot of air towards the device and you can increase its efficiency. And so this, I won't go into all the details, but this device has been optimized so it's about 80 times more efficient than if you just have a raw bulb that's in the room. And which is one of the reasons we want to study it because it's a very high performing unit. So 50 to 500 colony forming units typically in those spaces. We can inactivate them with regular UV or UV 254, or we can use far UV in the future as soon as we get devices certified by Health Canada. They have very equivalent rates of inactivation. Here's a far UV study that was done by the same university. And it basically showed that if you had ceiling mounted far UV lights shining down and you had a continuous flow of air through here in an exchange rate of 3 air changes an hour, 2000 CFU, not 50 to 500, but 2000 CFU, you could drop that level of contamination in that room to near zero almost instantly when you turn the lights on and maintain a virtually zero rate. So it can be done. So this is the device that Chair is going to be studying. We have about a $10 million budget for a big project over a couple of hospitals in BC and Manitoba to do a really large study, facility-wide study on upper air UV. And based on a unit that can deliver, well, in this case, 97 to 99.7% reduction in pathogens. If you try to equate that to HVAC, to mixed ventilation, that would equate to about 200 to 2,000 air changes an hour versus the 6 air changes an hour that we're using today for mixed ventilation. And you can see compared to other devices around the world, it's significantly higher, which is why we want to study that one. We're going to be using a new device that not only measures particles, but biological particles. So we will know how many bacteria, CFU per cubic meter, in each area in real time throughout the hospital. So we're going to map out the airflow in the hospitals to see not just particle counts, but bacterial counts. And it also has an approximation of live versus dead using fluorescence as well. So we're going to see live versus dead bacteria in our study as well. And what we're really trying to achieve, so we want to show that we can achieve at least a 90% reduction in exposure to pathogens in those rooms and at least a 50% reduction in the pathogens that accumulate on surfaces that are normally falling out of the air and landing and growing on surfaces, and at least a 30% reduction in our airborne HAI. So those are the main endpoints of the study, but there's a lot of other points to it too, to look at airflow and pressures and map out these hospitals very thoroughly to see what's actually going on in there, and especially take advantage of the fact that we can now see biological particles and map them out compared to how the HVAC system is designed. So here's our warm aerosols rising up. Here's our thermal plume rising off our bodies. And again, our supply air coming in, our return air going out. And if we can capture that or inactivate those pathogens with UV light, a field of UV light over people's heads, that's a very effective way to treat those pathogens before they spread through the rest of the room. It's expensive to infect people in hospital. They're typically in the hospital for a week. If they get an infection, they're typically there for 2 weeks. If they get a multi-drug resistant infection, they're typically there for 3 weeks. And so those extra 2 week and 3 week stays add up so that 20% or so of hospital beds can be occupied with people who got an infection that didn't come in with that infection, but picked it up in the hospital. And so not only is it very expensive to treat them, it's very expensive to have those beds tied up. It's very expensive to back up the emergency departments, to have, the overcrowding, chair care, hallway medicine, et cetera. And then the extra costs of treating all of those people, we have to look at the greenhouse gas costs and the solid waste costs and all the environmental costs, the energy costs, et cetera, that go along with that as well. So it's not just the treatment costs, it's the operational costs, about 20% of the efficiency of a hospital. So if we can put in EIP, we can have significant reductions in all of those things, in exposure, in HAIs, and treatment costs, wait times, et cetera, and we can calculate that return on investment. It's a project we have ongoing now with WHN, is to calculate develop a standardized methodology for calculating that cost benefit analysis in different categories. So what is the impact of the healthcare facility? What is the impact on their processes? And then what is the impact to society? So that's the patient and their family, the quality adjusted life years, the impact of family finances, the impact to productivity in the workplace, the impact to tax revenue, the impact to social services costs and healthcare costs ongoing to people who get infected. There's a lot of different things that factor in. This alone is enough to pay for EIP over and over and over again. This is about 10 times more than what even this is. So anyway, we could invest, say, $1 million, for example, in our ORs, and if we get the effect that studies show we should get, we can maybe save $4 million in treatment, but we can get an extra value of $5 million in more knees or hips or whatever it might be, going through those same ORs with the same people, people that didn't have to come back in for repeat visits. So, we could get a $9 million return from our $900,000 investment, and over the life cycle of the facility, that really adds up. So a quarter billion dollars. And that just, so this is a typical cost benefit that you would do in when you're designing a new hospital now, comparing, laminar airflow with EIP, et cetera. Here's, you can look at the hospital rooms, which are about 70% of the HAIs are happening in the room. So you can spend $4.5 million, maybe get an $18 million savings in treatment, but a $59 million boost in your productivity for a total value of $77 million. So $2 billion return from a $4.5 million investment. It's quite a no-brainer. And here's where I think grassroots advocacy can make a real difference because most of these are being funded by provinces who are paying 90% of the capital cost of a hospital. So this $4.5 million is the total, but the hospital foundation only needs to raise 1/10 of that, 450,000. And that's not usually hard to do, especially if the hospital knows they can have a huge return on their investment. So we've had a couple of examples where hospitals have, the foundations have gone out and done fundraising, and we're talking to other ones right now. And I think that's a place where maybe we could work with the Canadian COVID Society. If everybody has a hospital in their hometown, they're always undergoing renovations, they're doing projects or different things. If we can, chair can help the fundraising for the 10%. We can help walk people through the process. We can help deliver the message. We can help deliver this return on investment message, etc. There's a real opportunity for grassroots advocacy to lead to real action on a tangible level because of this return on investment, right? If you only have to raise 10% locally to get the province to kick in for EIP, it's a very, very significant opportunity. And so you can do that across the whole country, 95,000 hospital beds. We could spend $3 billion and save 8 billion in treatment, 28 billion in productivity improvements. And so overall, it's $1 trillion over a 30-year life cycle. We can't afford not to do that as a nation, as a country. Right? So we're really focused at Chair on this national EIP retrofit program. If we look at the $19 billion that we spent on the reacting to the airborne pandemic in the first few weeks of the pandemic, and then the 600 billion that we spent the first 2 years to support society through the first 2 years of the pandemic, and then the long-term costs, which you all know about with long COVID, et cetera, that's generational, which would be measured in trillions. That $19 billion could have put in EIP in all the major sectors of our economy. It could have prevented that whole meltdown, that whole thing. And so that's really the message we're trying to deliver. Here's our $19 billion here. We really want to target hospitals and schools first. So, but if you add these up, daycare, public spaces, hospitality, that's $19 billion. We spent that in the first few weeks of COVID. There's already a $5 billion that's set aside by the federal government over the next 3 years in the Build Communities Strong Fund. That funding is to be matched by provinces. And so you go province by province to say, we want to do X for emergency departments or for EIP or for whatever. And so we're trying to work with provinces now to make the pitch for EIP to access that funding. There's a direct delivery stream now. So if you're building a large hospital in your backyard now, Chair, like a not-for-profit, can lead a group with the hospital or with the construction team to try and access those funds to add EIP into that project. And again, just on a normal basis, the hospitals only need to raise 10% typically for EIP. So we're involved in a number of different areas here, and we want to keep that going. Speak with one voice, find the champions is really kind of the key. We'll keep working on CSA standards and clinical trials and trying to push people to do more. But we could really use your help in reaching out to hospital foundations and local MPs and local MPPs. Local is where it's going to be until we can get a big national program going. And that's really where we can make effective change. And just one example of a collaboration. So the Canadian College of or Coalition for Green Healthcare, which started 26 years ago, I've been involved with for quite a while. Dr. Miles Sargent runs that organization now. He's also a professor of medicine at McMaster University, as well as a doctor, and as well as the Coalition Green Healthcare lead. And he said, okay, I've got 3 years with these med students. And I want to make sure that they know all about EIP when they graduate. So give me 2 slides. They only want them to know 2 slides for the 3 years. And so here's the 2 slides. So We want to reduce 90% air, water, and surfaces. And here are the number of people approximately who get affected every year. Hundreds of thousands, more than 10,000 are going to die. A lot of that is preventable, and it costs at least $10 billion to treat them in hospital. And why would a doctor care? Because they are the allies that people listen to. And if we could just get that message through to the med students, he felt that that would make a real difference to the graduating class. More of them can be like Dr. Dick Zoutman, carry the message out there for what, will really work. Anyway, I do want to thank you for letting me speak and talking about how we could work together, and just to thank you and congratulate you for everything that you've done already and everything you're about to do. And I couldn't be happier to meet such a great group. So thank you.
Well, thank you very much, Barry. What a wonderful talk. You've given us a real rapid fire review of the technology that we can apply and made a very, very strong and compelling case for prevention. And we know the hierarchy of controls, and you're coming at it from the top of the hierarchy, not from the bottom, which makes all the difference because the impacts you can have, you're talking 90% protection. That makes a huge difference. I'd like to open it up to questions. Lance and Annie Claude, if you can help me understand how we can get people's questions through who in our audience, and that includes everybody now who's attending this webinar to offer questions. Lance, how are we going to process questions tonight?
I have the Q&A open and running. I'm gonna make you host, and it should show up under the More button, and then you can
The more
read through.
button. Okay, I will press my more button, and there's a Q&A button. How do you like that? Just like he said, Lance is such a cool guy. This is great. All right, so I have a question asking us if this presentation from Linda Dalpe, whether this presentation will be available on the Canadian COVID Society YouTube. I am hazarding a guess, yes. Lance, am I out to lunch on that?
No, we should be able to do that. It's recording, so we should be able to
Okay,
share
so
it.
the answer is yes. Yeah, I got it right. Very good. This is from Alash. Oops, it moved around. Tekshen, what is the outlook for the next 5 to 10 years for prevention? Barry, what's the next 10 years looking like?
Well, I think it's looking pretty good. I mean, I'm a bit of an optimist, but I mean, we already have these technologies going into different hospitals. It's not like we're starting from ground zero. I would say it only takes 20 years to become an overnight success, right? And they say it takes 17 years for a new idea or a good idea to be
Yeah,
adopted in healthcare. Well, we're whatever, 12 or 13 years into that. So like the ball has started rolling. We had a bit of a hiccup there with Health Canada wanting to register UV products, and that just put a freeze on everything for 5 years, which was a kind of an interruption just as things had gotten going. But that's restarting now. And so I think the next 5 to 10 years look pretty good. We are really focused on trying to hit a home run with this national EIP retrofit. And
yeah,
I don't know whether that's going to go or not, but certainly a lot of things are coming together that it looks like it could. And Canada's really taken the lead on EIP. Like we have more advanced technologies and more everything
yeah,
in this field than anybody. And it should make for a good story to be funded. You know,
yeah,
it's a Canada Healthcare Act. It's administered provincially, but every Canadian is supposed to have access to similar healthcare. And it doesn't seem right to build safe hospitals in one province and not in another. It really should be a national program, I think.
yeah,
And if we stop and think about how we've normalized hundreds of thousands of people getting infected every year and tens of thousands of people dying every year because of the infrastructure of the hospital, um, we should really give our heads a shake. If there's a way to get it funded in your area, we should all be reaching out to that local hospital foundation to say, hey, I've got an idea. Why don't we talk to chair? Why don't we see what we can do? Why don't we see if we can put some EIP in there and significantly reduce our exposure? So I think if we can get enough people talking about it, I think we can get the ball rolling. And I think that'll really help the feds take notice for the national.
Yeah. Well, your comment about how long, how long it takes for things to be adopted is a reality. I know that one of the studies that we did was seminally important in showing that a private room was a safer room. And we published that paper in the early 2000s, and here we are now, 20 years later, it's showing up in CSA guidance and in design requirements for private rooms.
And,
You know,
and post-evaluation of hospitals built to that standard.
yes,
So some of the first hospitals that were built to that standard, they went and took a look at the HAI rates, and there's literally 50% as soon as you build them to that standard with 50 single
yeah,
patient rooms.
yeah, for sure. I'm going to move along. Dorothy, I see your hand up, our newest board member.
Uh, yes, it's only because as the way the setup is, I can't put a question in the question and answer. So Barry, I have worked with and for unions a lot of my working life, and so I'm wondering where things are at in terms of this effort, and you talking to unions, getting unions on side, that kind of because if you're going to actually have people use stuff, you have to have processes, on the job, and we know from examples in this pandemic that individual union members aren't always well educated as to why certain things are useful, whether it's a respirator
Right.
or other kinds of prevention measures. So I think that they're an important player in all this, and just wondering what your connections are or where you think that might be going.
Well, we can always use help in getting the message out, Dorothy, to unions and to everyone. Really, for the first 10 years or so of chair, we were really focused on technology development, research to validate, the whole concept and the materials and technologies and the approaches and all of that. And now we're pivoting to implementation. So that's fairly new for us. We've only been doing that for a little over a year now. And so now it's all about the messaging, getting that message out because we feel very confident that we've got the bases covered that we need to cover now. And but it took quite a while to put the whole package together. People used to just say, "What's the one thing that I can do?" Okay, well, there is no one thing that you can do, right? You need to do this for air, this for water, this for surfaces, and this for the combination. And one thing, there is no one silver bullet, right? And and copper's better than silver, by the way, for in microwave.
Yeah.
Great. So Barry, here's a question from Ramona Wall. She's asking that you're piloting a project to put UV in some long-term care homes and hospitals, wondering which organizations got picked and how is the project going?
So we haven't started long-term care project yet. So just the hospital project first. So the long-term care is to follow after that.
Yeah.
Sorry, was that somebody from one of the hospital or one of the long-term care facilities that put their hand up that wanted to be included?
Well, that was from Ramona, and she was just asking about, what hospitals have been selected. I don't think that process is completed yet.
Yeah, we're down to the very short strokes. So there's one in BC, and then there's Winnipeg Health Sciences in Manitoba.
Yeah. So,
I won't
and-
comment on the BC one just because there's,
Yeah.
things haven't been quite finalized, but it's getting close.
So here's a question from Anna asking about graphene-based coatings on HVAC filters. She mentions the brand Zentech. Have you thought about or looked into graphene-based coatings on HVAC?
I looked into graphene for respirators and things quite a while ago, not specifically for air filters. I think one of the things with graphene, and not just graphene, but there's other approaches as well, is the idea that it can break down biologicals on the filter itself. And so over time, you don't get as much buildup and flow resistance on that filter. And so another company that I know of that's got a different technology is called C-Polar. Their claim really is that you get 3 or 4 times more service life at the same pressure drop that you would normally. You don't have to change out your filters nearly as often because of that antimicrobial action. And
Right.
I haven't seen the data on graphene and filters, but I suspect it would be similar.
Right. Margarita asks a more general question for the society. If we're planning on doing a video for lay people to understand what COVID is and what long COVID is, she would like to discuss this, and she's been berated for being COVID cautious. You're in fine company, Margarita. It's very frustrating. We've all been, beaten up over that. Yes, we will be developing videos, and if you want to get involved, let us know, and we would love to have, involvement from people who are on the front lines here. Is Chair, sorry, these are bouncing on. Will Chair be involved in the development of a new hospital in the new Kitchener-Waterloo Hospital?
Yes, absolutely. So I used to work at that hospital years ago. My co-founder, Richard Dixon, used to work at that hospital after I did. And we've done a lot of our research work with the University of Waterloo. I used to be a visiting scientist there, blah, blah, blah. We worked with them forever. So a lot of our stuff that we have validated at University of Waterloo, they are the innovation partner for the new hospital there in Kitchener-Waterloo. And we've had foundation meetings. I think Keith McGlowan I saw was on this call. He's a board member as well, and he and Richard Dixon have had meetings with the hospital foundation and with other people at the hospital. And so, yes, Chair is very much involved in that project.
That's great. Laura is following up with the question about is what Chair is involved with for hospitals be applied to schools and office buildings?
Absolutely. Yes. Yeah. Hospitals, I always focus on first. They're not only 25% of community transmission typically, but they bring the highly pathogenic and novel pathogens into communities. You have global spread through the hospital healthcare networks of any new pathogens, and then hospitals are incubators for multi-drug resistance as well, and so they have to be tackled over everything. But when it comes to volume, schools are the #1 contributor usually to community transmission, right? Typically 40% of COVID was through schools. And
Yeah.
so we definitely need to do something there. Upper air UV is perfect for classrooms. That's where it started almost 100 years ago in the 1930s,
That's right.
was in schools.
That's right. Nancy asks, and thanks to you for your talk, but also asks, what are some of the steps or the first steps for retrofitting what are older hospitals? Some of our hospitals are pretty old.
Well, number one,
short answer.
number one is bathroom auto UV. 50% of disease transmission is probably coming from the bathroom, right? Everything is aerosolized in there. Everything comes out with #2 when you go to the bathroom, and everything is flushed into the air, forms of fecal veneer and everything. And stuff is floating in the air, floats out into the patient room, lands on you, and it's carried everywhere. When you wash your hands in there, stuff is going down to the sink drain. Those organisms live for a long time in biofilm, and then they're re-aerosolized. Every time you shower, bathrooms are #1. And with just a simple device that you never have to touch, it just automatically flashes the room. Every time it gets used, you can maintain that as a very safe space. So I would start there always. And #2 would be upper air UV for continuous air disinfection.
Yeah, you get a lot of bang for your buck, and it's not quite plug and play, but if you have some good electricians, and a screwdriver, you can get it done.
Very simple, right?
Yeah. John Osborne has a great question for the society, with Chair and Canadian COVID Society. How are legacy foundations like Heart and Stroke, which I assume want to tackle all things relating to heart outcomes, and how is it they aren't reaching out to COVID Society, and how can Heart and Stroke, as an example, not have realized the massive impact that COVID has on heart health? Well, if you absolutely, John, agree, and that's going to be part of our advocacy plan for our 3 actions here. The Canadian COVID Society is talking to them. One, they're very well established. large national not-for-profits and charities, and we want to talk to them. And we will, follow up with them. That's a great point, because we know that long COVID has a huge effect on cardiovascular health, and with increases in strokes, heart attacks, and what have you. Adriana,
Thank you. May I add to that answer?
please do. Yes.
Thank you. Just so you know, as part of the theme this year for the impact of COVID in the heart and cardiovascular system, we did reach out to Heart and Stroke Foundation. The process on getting a partnership through them is a little bit more complicated than smaller institutions because of the complexity of their organization and what have you. Excuse me. So we wanted to start with HeartLife Foundation, which is more like patient-centered and more direct impact to the patients, where we can communicate easier, if you will, to some of the clinicians and then start building up. Our goal with the Long COVID Committee at the Society is to partner with a number of organizations on the impact that long COVID has on every single part of the body. So we want to partner with the Canadian Lung Association. We want to partner with the Brain and Stroke Association. We want to partner with all of those one piece at a time, but we want to start building the reputation with more patient-centered organizations first before we can grow up to the massive ones. But it is in the works, and they have been reached out to.
That's great. Saying there you go. Our long COVID committee is leading the pack here, as always. Sharon asks us a related question: is how does someone take this kind of information and take it to their workplace? They're worried that their workplace is not safe, which is expected. And how do you get workplace? How do you get management? How do you get the facility management and employers and even unions interested in this? COVID Society has some experience with that in advocacy. We are dealing with a number of files where organizations are coming to us, and we're dealing with the unions directly because there's a power in numbers there, and both in national unions and provincial unions, to make them aware of some of these issues. But it's a massive undertaking. So that's why the Canadian COVID Society needs to push its membership, because the job we are trying to do is kind of like climbing Mount Everest. It's huge and it's straight up, and there's a snowstorm all at the same time. So and you can follow up with Barry, Sharon, and he's very generous with his time and with his knowledge if there's some specific items. But I mean, just installing some of these new UV systems, literally you need a screwdriver, and a ladder. Last question goes to Michael Pappas. Just curious to know if there are any vaccines in development that may be effective preventing COVID infections. Okay, well, we have had I'll try and tackle that. We've had the mRNA vaccines and the protein-based vaccines. They started off being 94% protective, if you remember, on New Year's Eve on 2020. But of course, the virus was one step ahead of us, and we ended up with Alpha and then Delta and so forth. And so we now have the COVID vaccines that we have an efficacy, right up front in the preventing disease, or actually preventing you from getting COVID, in the 50, 60, 70%, depending on the strain, depending on the individual. That wanes fairly quickly. So ideally, you get the vaccine in the spring and in the fall, although getting a spring dose can sometimes be a bit of a thrash, convincing people that you should get it. But that is the optimal. New vaccine research has been hampered by the changes in the scientific environment in the United States. because the NIH was doing a lion's share of that work. They're not the only ones. We have excellent vaccine research at Dalhousie and at the University of Saskatchewan and throughout Canada. And so, more of this research needs to be done in developing a vaccine platform, and it's underway. That, for example, could be inhaled, could be even taken orally, and that research has made leaps and bounds in the last 7 years, and let's hope that it continues. So with that, folks, I see that it is now 9 o'clock, and I want to thank you, Barry, for an exciting talk. The questions tell you had everybody's attention, us all sitting on the edge of our seats. And it's a pleasure to work with you, and I look forward to seeing our UV light project coming to fruition.
Yeah.
I'd like
Do you
to,
mind if I just say one thing,
yeah,
Dick?
yeah.
I see Dr. Leslie Kaza is here, cardiologist from Edmonton. And I just want to single him out, because I know it'll embarrass him, as a role model, as an example of what every practitioner out there should be doing. He not only wears a respirator, he offers them to all of his patients. He doesn't, encourages them to wear them. He has air purifiers in his exam rooms, and he has auto UV in his bathrooms. If we could get other people in healthcare to be like Dr. Leslie Kaza, that would be extraordinary. And hopefully people can talk to their local doctors or to whatever, and have them call Leslie and say how easy it is. Sorry, I see a hero like that or a champion like that, Dick, I just want
Yeah.
to single them out and,
Yeah.
and point them out.
Thank you, Leslie. He's a great friend and a great colleague, and his leadership makes a big difference. And it just takes one of us to get the ball rolling. And when people see that, people will follow suit, and wish more we're doing it. Again, it's the lack of information. It's no one showing leadership, and the Canadian COVID Society wants to fill that gap to show general leadership in this, and let Canada know, and let our politicians and everybody in Canada know that COVID is still with us. It's different now than it was 7 years ago, but it's still a very serious health problem.